I'd like to thank the ABC for bringing me out. I'm the past president of ARP. I think it's important to note, I don't think anybody mentioned that Don, the previous speaker, is the new president. And thanks for being here, Don. So we're going to talk about true facial emergencies in the ring or in the cage. Or why did he stop the fight? I think that there's a whole lot of things that go on in a fight, whether it's a ring or a cage, that the casual observer, ringside, judge, referee, inspector, should be able to recognize as that's an emergency. And unfortunately, there's some refs and some judges who don't recognize those. So I think that's just why I want to put this stuff before you. This is a very, very short lecture, and some of it is an abbreviated form of what I did last year, just to kind of cover the lacerations, just to make sure we're all on the same page. And then there's some new stuff as well. I'm also a member of the Oklahoma State Athletic Commission. So we're going to talk about facial lacerations. We did this a little bit last year, and just basically what is a bad cut and what is not a bad cut. We'll talk about all of these. You will know in the next 10 minutes which are bad cuts and which are not. And you may be surprised sometimes as what's a bad cut and what's not. So in med school, you don't have to go to med school to learn this stuff, but in med school we learned a whole bunch of stuff, like the surface anatomy of the face, how to name everything. And believe me, we knew it for the test. We lost a lot of it after we took the test. We had to learn the major structures of the superficial face. We dissected the superficial face. We learned all the arteries, all the veins in the face and the neck, all the cranial nerves. But that's all kind of water under the bridge now. What we really want to know now is what's important. What's important are the nerves that supply the face, the cranial nerves, and references to what is a bad cut and what's not a bad cut. USA Boxing and IEBA kind of together came up with a little manual for ringside physicians, and this is kind of the gold standard right here. And it's not very helpful, I don't think. That's why I kind of put this together. I run into many, many, many docs who just basically say, I don't know. You know, and I've had them call me and say, hey, I got this laceration, or send me a picture, I just don't know. So I think it's important that everybody knows what's a bad cut and what's not a bad cut. I updated the image that IEBA and USA Boxing made, and I kind of put together a dummy's guide to lacerations. So it starts off with the skull. Everybody's got a skull, and they're all built about the same. Think of the plastic ring that carries a six-pack of Coke, and put that on your face. And that's going to make it a whole lot easier. There's two holes right here in the middle of your eyebrow. If you want, just reach up and feel. You can feel that there's a little depression in the bone. It actually kind of hurts there because there's a nerve coming out. That's why it hurts. If you just reach up and feel, there's one there. There's one on each side. There's one right here. This is pretty easy to feel. There's an indention there. The infraorbital nerve is coming out right there. And there's one right here. And that's also pretty easy to feel. If you push hard, that's going to hurt specifically in that area. So those three areas, that's really what I'm worried about when I'm talking about facial cuts. Those three areas right there. A deep cut anywhere near those cuts, near those holes, is a bad one. So how do I know where those are? Well, if you look, they all line up with the pupil. Pupil is there, so you have the patient look straight ahead and then find where the pupil is, and those holes line up perfectly with the pupil. So we're talking about the supraorbital nerve on top, the infraorbital nerve on the bottom, and the mental nerve on the bottom as well. There's one other nerve that's not represented here, and that's the supratrochlear nerve. Where's the supratrochlear nerve? It comes out the same place that the supraorbital nerve comes out, but then it goes medial towards the nose. So any cut that lines up with the pupil and goes towards the nose is a bad cut. If it goes out, not a big deal. I don't like the way this keyboard's working. So let's just look at a patient instead of a skull. There's a fighter. Have him look straight ahead and drop lines straight down. Put in the circles, the supraorbital nerve, the infraorbital nerve, the mental nerve. Remember, the supratrochlear goes over towards the eyebrow. So that's it. 90% of the fights that get stopped for a cut is because cuts in these areas right here. Now, there's some special cuts. We call them absolute showstoppers. Any kind of a cut around the eyelid, the nasolacrimal apparatus, the tear duct, even if it's approaching, like this cut, that's not quite to the eyelid, it's not quite to the tear duct, but it's almost there. Man, you got to stop that fight. You've got to stop that, because once the cut goes into the nasolacrimal apparatus, into the tear duct, that's a major surgery to fix that. Laceration of the eyelid. I don't care how good your plastic surgeon is, that is really hard to fix. I don't care how big the purse is that you're fighting for, that is really hard to fix, and you need to stop that fight. There's another one, this involving the eyelid and the tear duct. You got to stop that. Absolute, there's no question about it. This is another one that's close. It's not quite to the eyelid, and it's not quite to the tear duct, but I would be scared to death to let that fight go on, because one more punch and it's going to extend into very dangerous territory. Now, any injuries that obstruct the vision. So if you got a swelling of the upper eye and it's actually closed and they can't see out that eye, they're done, because they can't adequately protect themselves. If they don't have full vision in both eyes, they can't adequately protect themselves. Now, this is a laceration that's not in a dangerous place. Doesn't fit the six-pack of holes, but if it bleeds profusely and it gets in the fighter's eye and he can't see, it's the same as a swollen eye. So a cut that's above the eye but not in a dangerous location will have a fight stopped if the bleeding is excessive and it gets into the eye. If you got a good cut man in between rounds, a lot of times they can stop that bleeding, but it's actually pretty rare to have a fight stop because the bleeding is so profuse that it gets in their eye. Another absolute showstopper, definitely maybe. Why do I say that? Some of you have heard this already. We're talking about a laceration of the vermilion border. That's the lip where the pink meets the skin. A cut there is really, it's not hard to put together, but it's got to be done precisely and perfectly. It has to be expertly done. If you have a cut that involves the vermilion border, it doesn't matter, upper or lower, and it's not fixed perfectly, for the rest of your life, people across the room will say, there's something wrong with that guy. It's because the lips just don't match up. And for the rest of his life, he's going to be called, there's just something wrong with that guy. There's something goofy about him. And it's that they didn't fix the lip. But it can be done. So that's why I say it is an absolutely maybe. If you got a lip that's just mangled, the vermilion border is totally mangled, it's time to stop that fight. Time to stop that fight. So this involves a vermilion border, and I would probably stop most fights. But let's say this is a title fight. This is a Bellator, a UFC, a WBA, WBC. You know, there's millions of dollars on the line. I'm probably not going to stop that fight, because just because it's in the vermilion border, when this fight's over, he's going to have a boatload of cash. He can go get the best plastic surgeon in the world to fix it. Now, in between rounds, if the ref comes and asks me to look at it, I'll look at it and I'll tell the fighter, hey, that's a pretty bad cut, but it can be fixed. Do you want to keep going? You know what they're going to say. Hell yeah, I want to keep going. So that's why we got different classifications. Is it a really meaningful fight, a meaningful purse, or is it not? When you close these, the very first stitch has to close the vermilion border. When I do these, I'll put in the stitch and I won't tie the knot. I'll put in the stitch and I'll just pull it together so it looks like it came together. And I'll ask everybody in the room. I'll get housekeeping, the janitors, the nurses, the med techs. Everybody come in and tell me that this is perfect. They all come in and say, yes, that's perfect. And most importantly, get the husband or the wife or the mom or the dad, anybody who's around, to come in and say, yes, that's perfect. And then you document in the note, everybody said it was perfect. There's not much chance of a lawsuit afterwards. If one person says, nah, it's just a little off, I'm going to start over. I'll just keep doing it until it's perfect. And it's just really important to do that. I mean, you can do this at the ringside. If you have docs who are suturing after the fight at ringside or at cage side, as long as you got really good lighting, you can do it. But you got to make sure everybody agrees that it's a perfect stitch. That's a perfect stitch. So to enhance the diagram, and to enhance docs who don't necessarily know, I came up with some zones, me and a guy named Dr. O'Donohue, we came up with some zones. Called Zone 1, the tarsal plate of the lacrimal sac. That's a red zone. That means you need to stop the fight. 2 is the vermilion border. That's another red zone. That means you need to stop the fight, unless this is a big payday. 3 is where the supraorbital and the supratrochlear nerves are, up there in the eyebrow and medially towards the nose. If it's deep, you need to stop the fight. If it's superficial, you don't necessarily have to stop the fight. 4 is the nasal bridge. And I include that because there's a lot of us that work USA boxing, the amateur boxing. In amateur boxing, if you have a broken nose, you got to stop the fight. In pros, not so much. In pros, if you have a broken nose, you can keep going. So I kind of have a caveat there on that. 5 is where the infraorbital nerve is, and 6 is where you can't hardly read, the nasolabial fold right here. You hardly ever see that, but if your doc wants the complete thing, there's number 6, and there's also number 7. It is out here where the superficial temporal artery is. Then 9 is where the mental nerve is. So I see people taking pictures. This will be on the website if you want to get this, and it's also on our website. I'm so fancy, I made the card a little bit even better so that if a doc is carrying this with him ringside, he can't remember what the supratrochlear nerve does or what the supraorbital nerve does. So he can say to the referee or the judge or the promoter or anybody who asks him, why did you stop that fight? He can say, well, it's in zone 3 and the patient may have numbness over his forehead for the rest of his life. Or it's in zone 8 and he may have numbness of his lips. It just kind of gives a clinical correlation of why these are bad cuts. Not really important to you, but it makes you look smart if you know this stuff, On the back of the card, I've got pressure points to stop the bleeding so that this is good for the seconds. If you got a bleeder here, you got a cut that's really, really bleeding here, you can put pressure back here to stop all that bleeding. If you've got a really bad bleeder up here, you can put pressure here to stop that. So you can have somebody putting pressure on the wound itself and a second person or a second finger putting pressure in the back, and it really helps. So just a brief exercise. Stop the fight or keep going. Stop or go. Stop. I agree. The nose is over here. Kind of hard to tell. The nose is over here. That's in the eyelid. It's approaching that medial part where the pupil is, but it's not very deep. I'd probably let that go a little bit. But watching it very closely. What about that? Let that go. Unless it's bleeding profusely. Then you got to stop that. It looks horrible, but there's nothing wrong with that. They can keep fighting. But it looks nasty. What about this one? You can go with that. No reason to stop that. That's way out lateral. It's not deep. It's not above the pupil. No reason to stop that unless it's bleeding profusely. Got to stop that. That covers so many zones. That's bad in so many ways. You got to stop that. What about this guy? Obviously, you got to stop that. Got to stop that. That's in a bad place. You can keep going with that unless it's bleeding profusely. Got to stop that. That's in one of the zones. This is a definitely maybe. I'd probably stop that. That's really getting mangled up. This is in a safe area, but if it bleeds profusely, you've got to stop. So I just blazed through this. I didn't mean to make all these come out like this and slide. So there's other things on the face that I think you need to know. I hope you guys feel like you're comfortable with lacerations now. Just sitting ringside or being a referee or a judge, you should be able to look and say, that's a bad cut or that's not a bad cut. But there's a couple other things I want you to know about. One's called a hyphema. Now, hyphema is blood in the colored part of the eye. It's called the iris. And it literally pools down there like this picture. This is what it looks like clinically. This is really a bad thing. When I was an intern, you got admitted to the ICU for this. Now you don't even get admitted sometimes. But this is a big deal. A hyphema is blood in the anterior chamber of the eye. And if you see that developing in a fighter, stop that fight right now. Here's another example of a hyphema. You see where we're looking? I'll make sure everybody knows what we're looking at. We're looking at the blood that's pooling right here. little meniscus. And here's another one, it's just pooling. Don't see it very often, but I think it's very important for people to know about it. What about this one? There's all kinds of trauma here. Notice that around the eye is blue. This person's been punched in the eye a whole bunch. But the redness is in the white part of the eye. It's not in the colored part of the eye. That is a subconjunctival hemorrhage, and that's not a big deal. Subconjunctival hemorrhage is blood involving the white part of the eye. You can get that from sneezing too hard. You can get that from coughing too hard. Another example of a subconjunctival hemorrhage. This can look hideous. I've seen patients that just sneeze too hard, and they've come in, it looks like this. I mean, that just looks awful, but it's not. It's not awful at all. It's not a big deal. Here's another one. It can involve the whole eye, but it's not a big deal. Subconjunctival hemorrhage, we don't care. These are all subconjunctival hemorrhages, and we don't care. So another red light, green light, looking at eyeballs. Stop the fight or go. Yes, sir? In the iris, it's actually, if you see blood in the iris, it's in the anterior chamber of the eye. It's actually in the functioning part of the eye. And that's a big deal. It can make them lose vision. Whereas the part in the white part of the eye, not a big deal.
Larry, just to add to that, you're a real setup for glaucoma when that happens.
Yeah.
In fact, even after when you've been treated, they need to be followed regularly by an ophthalmologist and checking eye pressure changes, because it just it disturbs what's called the aqueous humor at the trabecular system, suffice it to say, but very dangerous setting for development of glaucoma.
Stop or go on this one? That's okay. We can go with that. Go with that. Stop. Notice the subconjunctival hemorrhage and a hyphema. You got to stop that. Obviously, you got to stop. That's a hyphema. That's okay. That's okay. That's okay. You got to stop. See, you guys are experts already. Didn't even have to go to medical school. Stop. Please say stop. Other guy is anything that involves cartilage. If you have laceration that involves cartilage, like this, those are really hard to fix. And you should stop the fight. Yes, sir.
Doc, can you just explain back to eyes how age plays a factor, or is it irrelevant for a 20-year-old fighter versus a 44-year-old fighter?
Well, I don't like to see any 44-year-old fighters at all. But again, I think you're at a greater risk as you age. Everything is just getting structurally less sound. And can you add anything to that, Don? I don't think that the older you get, everything just has more of a tendency to break down.
Well, I mean, there's several risks to getting punched in the face or the eye. As we get older, we tend to develop cataracts. Trauma to the eye can induce cataracts, so you're getting a double bang for the buck, so to speak. The tendency towards glaucoma is greater. You can disrupt what's called the trabecular system, increased chance of having changes indicative of glaucoma. Things get a little weaker, so retinal detachments, all these bad things you hear about, we become more susceptible to as we get older.
All right, we're still on the stop and go portion. We all think we should stop this, right? It involves the cartilage. You got to stop that. You can go. One last thing is nosebleeds. See a ton of nosebleeds in mixed martial arts and boxing. I mean, it's just you get punched in the face and your nose bleeds. It's not really much of a mystery. There's only really two kinds of nosebleeds. There's an anterior nosebleed and a posterior nosebleed. An anterior nosebleed looks horrible. I mean, it looks like they're bleeding to death, but I can tell you they're not going to bleed to death from an anterior nosebleed. They are not going to bleed to death from an anterior nosebleed. Now, they may have trouble breathing because it's clogging up their nose, but nobody ever bled to death from an anterior nosebleed. Posterior nosebleed is a different story. On a posterior nosebleed, they can bleed to death. Those are bigger arteries back there. So the question comes up, how do you tell if it's a posterior nosebleed? You just have them open their mouth and look back there. If they've got blood pouring down the back of their throat, they got a posterior nosebleed. They need to go to the hospital right now. Fortunately, it's not very common, but I wanted you to know about it. And the last thing I want to show you is, this is called a retrobulbar hematoma. This is something that I want you to be able to recognize. This is the CAT scan. There's the eyeball, and there's the eyeball. And behind this eyeball, there's a big blood clot that comes from trauma. And that's what we're talking about, getting punched in the face. That's a blood clot behind the eyeball, and notice that it's pushing the eyeball out. This eyeball is out farther than this one. Like that, sticking out. It's called a retrobulbar hematoma. It just basically means a blood clot behind the eye. Notice on this fighter, how this eye is sticking out farther than this one. It's pretty easy to see from this view. I got some other views so you can see. This one's pretty obvious. That eye is sticking out. That eye is sticking out. That's a true emergency. You need to stop that right away. Sometimes it's kind of subtle. Sometimes it's pretty exaggerated. You know this guy's got a retrobulbar hematoma. So how do you treat a retrobulbar hematoma? This is the last thing I'll talk about. And you might not want to look if you've got a queasy stomach. This is the coolest thing in the ER to treat. I worked in a trauma center, so I kind of liked it when a retrobulbar hematoma comes in. The way you treat them is, if this eye is sticking out, you cut this lateral canthus, this lateral fold. You cut it with scissors, and you go digging in there for all the ligaments and everything that's holding the eyeball together. Get all that stuff free, and then the eyeball opens up like a door on a hinge. It literally just opens up. And you just go in and suck out everything. Suck out the clot, suck out all the stuff that's in there. You close the door, sew them up. It's really a pretty cool thing to do. It looks horrible, it looks graphic, but you can bill a lot for that too. It's a pretty good thing. All right, any questions about any of that? No questions? All right, thank you. I'm with the Association of Ringside Physicians. This is our website. The cards for the facial lacerations are on there. I think Mike may arrange to put it on here as well. That's all I got.